All right, everyone. I guess I'm going to go ahead and get started. Yeah, I guess now's the. So thank you, everyone, for coming. I know it's the first session of the conference. I appreciate everyone getting up early, at least earlier than some, and finding the room. I think that was probably harder than anything. So I appreciate it, and we do, and we look forward to the session. Let me. Just to get everybody started, I know that the title is Elective Genome Screening, its role in clinical practice and general health checks. And you can see the speakers we have today it's going to be a very interesting topic, and let me go over a little bit about what we're going to be discussing, what to expect. So we'll have Dr. Vincenzo Cirigliano. He's going to be talking about the technical aspects of what we do as far as the My Genome service. We're going to go into the details of that in a minute. And really starting off in the technical part of how is this possible? How's the biopipeline developed? Why do we use the platform of technology we use? And some of those aspects of how do you sequence a whole genome and then get a report that's 150 pages, very extensive, clinically grade. So we want to basically tell you how that's possible. Then we have Dr. Joel Fellis is from Illumina. And he'll be talking more about the Illumina platform, the NovaSeq X Plus. And then Dr. Izquierdo will go into the details of the service. What is this comprised of? What's in here? And what is analyzed? And then Dr. Michael Sandberg will talk about the physician experience, clinical examples, and actually how this has been, both Dr. Izquierdo and Dr. Sandberg, how this has been put into use in a clinical setting and the patient experience, patient management, and so forth. Let me go ahead and present our speakers, which we have Dr. Vincenzo Cirigliano. He was head of molecular genetics, general lab at LabCo and SynLab. He researcher, University College of London, and International Institute of Genetics and Biophysics of Naples, extraordinary doctorate award from Autonomous University of Barcelona, a member of the board of directors of the International Society of Prenatal Diagnosis. He participated in the Human Genome Project, and is internationally recognized for being a pioneer in the development and routine clinical introduction of innovative molecular tests and prenatal diagnosis. And then we have Dr. Joel Fellis, Vice President of Product Management and Marketing at Illumina. Joel is currently Vice President of Product Management at Illumina, where he leads marketing across the NGS platforms. Joel has been with Illumina for 14 years, and he's served as a commercial marketing lead for basically all the major product and technology launches over the last, well, I guess 14 years, right? And then prior to this, Joel was at the Lawrence Livermore National Laboratory in California, and he has a PhD from Wake Forest University, where he led research on population genetics, ecology, and epidemiology of wildlife diseases. We have Dr. Luis Izquierdo, is our Chief Medical Officer at Veritas. He's a graduate and doctor in medicine and surgery, extraordinary doctorate award from the UCM, Master of Science in Medical Genetics from the University of Glasgow. So yes, he's come back home, so to speak. And head of medical and genetic services in several university hospitals in Madrid, and has been working in the utilization of genetic medicine for over 20 years, founded one of the first prenatal diagnostic laboratories in Spain, prescribing genetic services through personalized genetic consultation. And that's very important because he's definitely one of the first physicians to do this in Spain. It's not a medical specialty that's recognized as such as it is in other countries, and he's been a pioneer in that field. And then you have Dr. Michael Sandberg. He's the medical director at the 90 Sloane Street Clinic and the London Genetics Center. He has specialist training in internal medicine, cardiology, echocardiography, and cancer medicine. He is keen in the cancer care of 90 Sloane Street, is of the highest level and ensure that has attended the American Society of Clinical Oncology, the meetings in Chicago for the past 7-8 years. He's also developed the cardiology and the ultrasound program at his clinic, 90 Sloane Street. So let me tell you about who Veritas Genetics is. This is the short story, I promise you. So we were founded in 2014. As you see to the right there, one of our founders is George Church. And I think everyone probably in this room knows who he is. One of his famous quotes is, "The genome will soon replace all other genetic tests because it is all other genetic tests and more." And I think that's an important quote because the four individuals here speaking and the topics will actually demonstrate how that's actually becoming a reality. And it's, it's very amazing to see. I've been now with Veritas myself for 5 years, and we've advanced incredibly, and it's closer and closer every day. So as far as Veritas, we are recognized as the genome company. We're the first to really launch whole genome sequencing with interpretation for healthy individuals, which is our focus. What we offer is genetic testing. We have a pretty extensive portfolio that we've distributed throughout the room here. We do interpretation and genetic counseling services, and I think that's where we really differentiate, is that we're focused on the interpretation piece. It's like, what do you do with that? Many people sequence, many people do many aspects of the value chain, or I guess the technical chain of how these services are produced, but our focus is interpretation, and we have a large team that does that, and expertise around that. And so, yeah, and you can see since 2014, we've been recognized in various capacities over the years as how we've progressed this utilization of whole genome sequencing in healthy individuals. I like to have this slide. This is more for someone like me, because I didn't introduce myself in the first day. I'm the Chief Business Officer at Veritas. I do the commercial and marketing part of it, so the boring stuff. But this slide is important for someone like me, because you're trying to understand why is whole genome sequencing so difficult, and what has been done by these individuals and the companies involved is so amazing where we're at now. If you look at, there's different aspects of genetics and services that are involved there. You have the genotyping, which is a very specific analysis, and if you look at that if you compare it to like a book, so it's a 180-page book, and that's the amount of information you get when you look at it in reference to the whole genome. And they have whole exome sequencing, and that is definitely much more coverage, definitely much more information. So you say 63 books of 500 pages each. And then if you look at a whole genome sequencing and how much information is sequenced and analyzed, you look at it's 4,200 books, 500 pages each. So you can imagine that amount of information and how this has evolved to become, from this clinical report, that's valuable for the proactive healthcare of an individual. And then you say, what is my genome? What is it comprised of? It is aimed to improve health and prevent diseases. It's the first genetic test designed to integrate genomics into patients' health checkups, enabling personalization of medical care. Analyzes the risk of common diseases, principally cardiovascular, cancer risk, and care conditions. The objective is to establish a specific approach for each patient. So proactive healthcare management is what the goal is. Additionally, other information is provided, such as risk alleles, carrier status, pharmacogenomics, and also we have some fun stuff there, traits and some ancestry that was just part of the overall report. You have all this information, you might as well do something with it, right? So that's how you see the traits and ancestry part. And then if you see it, the concept is it's performed once in a lifetime. So once you have the data, you can reanalyze it. You can see as science advances, we fully believe that as technology advances, that more and more information will be able to be extracted from this whole genome information. And then the key there is it needs to be, our service does include genetic counseling. Michael will talk, Dr. Sandberg will talk later about the consenting process. It's important that whoever wants to do this understands what it is, what it entails, what to do with the information, and so forth. So the pre-test is important, and the post-test is even more important. Obviously, if it's a boring analysis, it's not as important. But if you do find, which you almost do always find something, it's important that information is given appropriately by a physician. And you see some stats there. The analysis looks at over 650 diseases with clinical relevance. Incorporated into that is over 200 carrier conditions. The pharmacogenomics part is over 150 drug responses. So you're looking at how do you possibly adapt dosage, just areas to understand as you manage that. And then you have multifactor diseases and over the traits and ancestry that I've already talked about. So that is what's involved in this book here. And now we'll get into the more interesting stuff, as I've already mentioned, and I'll bring up Dr. Cirigliano to talk about the technical aspects.
Thank you.
You're welcome. There you go.
Thanks, Matt. Hi, pleasure to be here today and to share with you our experience and what we are doing in bringing genome analysis to healthy individuals, so on a large scale application basis. You will hear in much more detail how we did select the genes and conditions and diseases to be analyzed in healthy individual. This is not a phenotype-driven approach, it's a genotype-driven approach, so we don't have a patient with a given phenotype. We only have to select which area, which region of interest in the genome to be analyzed and reported on to avoid additional stressing and additional burden on the other medical services. So this is just to give you an idea of what can be done out of a genome in healthy individual. Like we analyze for cancer susceptibility genes, cardiovascular disease, more common risk factors like the involved for clotting disorder. We also have a session for carrier status, so recessive disorder that can be transmitted to the offspring, neurological disorder, metabolic and endocrine disease, and a series of disease that affects or can affect different organ health. So the idea, and this is why the company was founded back in 2014, was to try to develop systems that allow a cost-effective and efficient way to analyze this sort of condition in the general population. From a wet lab point of view, genome sequencing is relatively simple, and even more nowadays with the new chemistries from Illumina. We actually have a fully automated these on Hamilton robots that can be, whose decks can be highly customized to bring the sample from the original collection tube all the way to the DNA extraction, library preps, quantification, normalization, poolings. So for genomes, basically the throughput is given by the current throughput available for sequencers. We use Illumina machines and NovaSeq. So we can start with full batches of 48 samples because the current throughput that we can have on the largest flow cell, which is the S4, is about 24 genomes per sample. So we can input 48 samples into the beginning of the automation, end up with 2 pool of 24s that are then sequenced onto independent S4 flow cells. This happens, of course, is governed by our LIMP system. So when during the sequencing, the data is sort of real-time streamed into our clouds where all the computing happens. So after about a couple of days of sequencing time, the data is there already, and the biopipeline analysis can start automatically. Again, this is important, the connection with the LIMPs and the full integration of this with our system and also the analysis, because soon after the demultiplex, all the samples, so all the FASTQ file can be then processed in parallel for each individual patients. So after the very first step, which are common to all kind of whole genome sequencing test, which is the BCL to FASTQ conversion, alignment. One difference here is we use 2 different colors. We generate 2 independent VCFs that then are merged, annotated, and then each of these goes through, and this happens in parallel for all the samples in a run, and then all these goes through specific analysis module that are driven by the system that has been built in Veritas. So the first part is what you can see here, which is Veribench, is a sort of dashboard where we get inputs for coverage and all the QC metric of that particular sequencing run, and then all the output results of the biopipelines for the different modules like ancestry, PGX, risk allele genotyping, and the variants that are filtered case by case. This helps a lot with the automation because a big part of the what we are going to report into the genome can be completely automated. And these are the part of the report that are related with basically genotyping very well-defined SNPs. Or region, like the one that are involved for PGX haplotyping, all the risk alleles, common traits, and ancestry. Once the QC metrics are approved in Veribench and there are no QC flags to be manually reviewed, basically all this section is ready to go straight into the reporting because we have already disassociated into our databases with a write-up for that particular genotype, that particular condition, that particular gene and patient. Sorry. The other part then is, and this was what Matt was referring to, where the expertise of our medical team comes in, is for the variant, the medical to be reported into the clinical section of the report. Here also we have developed, and this is growing every day since the very beginning in 2014, another proprietary tool which is called Vapor. Is variant curation tools that allow all the variants that are new, so not described for the first time, as long as they pass some filters that I will show you on the next slide, to be manually curated, annotated, and even complemented with all the information that the curators use to then classify the particular variant. We can also upload including PDF of papers and all the references that then are going to be pulled out into the report. This is useful because for all the variants that are already there, or once this happens on a particular variant on a particular case, patient, next time the variant shows up, this process doesn't need to be repeated as long as the metrics are approved and the write-up from the medical team is within 1 year, doesn't need even to be reviewed, so can go straight to the reporting section. So the variant, the selection variant for Mendelian disease is based on quite common criteria. Once the region of interest, so the genes that we are going to analyze and report on are included in the region of interest that filters as a first step the variants that we want to go that we want to have shown on the report. Well, the first filter is quality, of course. If coverage is not sufficient for some particular region, this is flagged. Then variant undergo basic filtering, like population frequency, the type of variant, and if they have an entry like pathogenic or likely pathogenic in ClinVar or disease causing in ESHG and D, and also new variant not described, but which are predictive of causing a loss of function, truncating. These are also then made available into our database for manual curations. So once these happen, variants are classified according to the SCMG. If are already classified, this can go straight to the report. just with 2 clicks of approval on the quality metrics. And it's important because in the Vapor tool, that particular variant is associated to the write-up that describes the disease, the gene, the variant, and its effects on the phenotype of the patient. So it's made to reduce as much as possible the time needed from the curators that can then dedicate most of the time to deep curation on new variants. We only report in healthy individual likely pathogenic or pathogenic variants. We don't report VUSs or benign variants. This can be subject to reclassification either after 2 years or if it shows up, the same variant shows up in another patient. It is to reclassify. This is if it's still within these 2 years' time. So you will see in the next talk, in the next slide, how the genes has been selected and how these are reported to the patient. Matt showed you that the genome report is about 150 pages long. We also provide an easier version of the report to read, which is web-based, so it's more easy to be accessed by clicking on different sections. But the structure of the report, which again is a genotype-driven, not phenotype-driven, is for a healthy patient, is designed to simplify as much as possible comprehension using sort of color barcodes. Like a red is something that requires immediate attention to be reviewed with doctors. And these, it goes into a section of the detailed report and also in a small resume, which is in the very first pages of the PDF. Then yellow coded results are for good to know and good to stress and discuss with your doctor because might have impact, on your lifestyle. And then the gray area, which are actually sections that can even be removed from the report if not required, like common traits, which are just sort of out of curiosity, or a small ancestry showing basically just the percentage of origin of our ancestral origin. So to make it simple, we developed a fully integrated system that embraces from the input of a biological sample in the laboratory all the way through its wet lab processing, bioinformatic analysis, and curation and report generation tool to try to bring this as much as possible into a large-scale clinical application, which we expect to happen, and the only way that can happen in healthy individuals. To do this, the very first step was the selection of the regions of interest to be reported in healthy individuals. And these are also sort of dynamic. We are sequencing the whole genome, so we can then update regularly on the same data as long as new advances or new area of interest arise. As an example, patients that we sequenced and reported on 3, 4 years ago nowadays can receive their polygenic risk score reports for different conditions without going back on the original sampling collection into a clinic. The efficiency in doing this, I would say one single operator, just to give you an idea, can easily handle and report once the sequencing is finished, 2 or 3 genomes during the morning before lunch. This is only possible thanks to the development of the system and the integration that has been a big part of the previous work of our company, and with a particular mention to Vapor, the database, which associates variants with the clinical write-up, and is a huge improvement for gaining the efficiency. So again, it's a test that we can perform only once in a lifetime, and keep then updated over the time. Our clinical team and our geneticists can provide you with detailed result of what happened once we apply this in a large-scale clinical setting. But before that, I want to give the word to Joel for new updates from Illumina. Thank you.
Great. Thank you all for joining us this morning. Thank you to Matthew and the team at Veritas for the invitation to join today and present and talk about some of the technology we've been developing at Illumina and some of the technology being deployed at Veritas. I have to say that I'm incredibly impressed by the platform that Veritas has delivered. It's actually very, very well aligned with some of the key drivers and key imperatives at Illumina. Our corporate mission is really to unlock the power of the genome, and this is something that permeates everything we do as a company at Illumina, across research and development, across our marketing and commercial organizations, our medical affairs, and just really looking to how we can unlock the genome and provide more value to researchers, to clinicians, and ultimately to patients to realize the full potential of genomic information. What I'm going to talk about in my brief slides is talk about a new platform that has been in development at Illumina. This is an effort over the last 3 to 5 years. It's involved 1,500 of my colleagues across 3 different continents, including scientists, engineers, developers, and designers, to bring what we believe is a revolutionary new sequencing platform to the market, really to make whole genome sequencing and similar applications much more broadly available, accessible, and affordable. To do this platform, we really look to redesign our high-throughput sequencing technology from the ground up. And with the exception of the Illumina logo, there's been a massive amount of innovation in every key aspect of the platform across the core SBS chemistry. This is the first reinvention of our chemistry in the last 15 plus years, really designing this up for much faster speed, much better accuracy, much more robustness, the ability to ship chemistry, our reagents at ambient temperatures and remove the cold chain from shipment, increasing the data density of our platform, allowing our platforms to generate a lot more genomic data from the same sort of flow cell size. This increases the overall power, throughput of our sequencer. It also dramatically lowers the price of sequencing to the end user. We've also implemented state-of-the-art processes and techniques from the semiconductor industry to allow us to manufacture flow cells at high scale with the highest level of QC and robustness, also while significantly driving down the cost of sequencing, which we can pass along to our customers. Similarly, to take advantage of all of this, we've improved the imaging of our platform to operate at much higher resolutions, And you'll see in the next slide, or the next coming slides, we've generated a tremendous amount of data. And to manage that deluge of data, we've embedded our informatics platform on board the instrument to simplify the analysis of variants or calling of variants, and just the overall data management and processing of a significant amount of data coming off the platform. The new platform that we launched back in September, announced to the world back in September, is the NovaSeq X series. This is really the most powerful NGS platform on the market. If you are a production facility and we're going to do nothing other than crank out human genomes, you could do roughly 20,000 of these a year. We've also made some significant improvements in the overall sustainability of our platform by removing the cold chain from the shipment of reagents. There's about a 61% reduction in climate change impact with this platform. This doesn't impact the ability to do elective genome screening, but it's an amazing thing to deliver to our customers and reduce our impact on the environment. We've also been able to reduce the waste stream of packaging by more than 90% with this platform. And we're delivering an incredibly cost-effective, high-value genome in the range of $200 to $300 US, depending on how aggressively or conservatively you want to multiplex. And I also want to point out that that price also includes onboard analysis, so onboard secondary analysis and variant calling with our Dragon technology, which we believe is the most accurate variant calling out there on the market. We're really, really excited about this platform, what it will enable, the ability to generate a tremendous amount of genomic data to drive discovery. Since we launched this platform back in September, we've seen really broad adoption across leading institutions in Europe and US and the rest of the world. It's been really exciting to see the adoption of this platform. And then since February, we've been shipping this instrument, and it's been equally rewarding to see it out in the wild, to see it in the hands of our customers, and to see them putting it to use, and really just seeing how they're going to unleash this new technology to drive discovery and unlock clinical insights. And the development of this platform, really what we were looking to do was increase the overall capabilities of what our customers could do with this platform. And in a research setting, you can think about how this level of throughput and cost reduction can drive larger projects. It can enable deeper sequencing and more omics. It can allow you to take on much broader studies, and you can do it more affordably. And this may be kind of a strange message to talk about in a seminar focused in on elective genome screening, but I would argue it's actually incredibly important. This is what drives utility and insight into the genome. There's a lot more discovery that needs to be had to truly unlock the genome and to drive meaningful insights. So I would argue that by enabling this sort of discovery power, it makes the genome much more useful, provides much greater value over time, and really is an important, albeit critical, although maybe critical step on realizing the true power of genome sequencing. And this is really critical because we think that whole genome sequencing is going to be critical across a broad range of markets, from reproductive health, across genetic disease research and testing, across cancer research and oncology testing, infectious disease, and even outside of direct human health applications, but in the fields of agrogenomics. We think this level of sequencing is absolutely required to truly unlock the power of the genome. I want to thank you for the opportunity to speak and join the panel, and I believe Dr. Izquierdo is going to join next. So thank you.
Okay, thanks very much. Thanks very much for coming this first day. Okay, so I'm going to talk a little bit more about our elective genome service, what we call it MyGenome, that the technical basis of the service, of the platform and everything has been explained by Dr. Cirigliano. So why do we think that it's important to do elective genome? Because there are a lot of conditions that the population they are carrying these conditions, and the adult population that they don't know. So we have that between 10 and 15% of all the cancers, of the common cancers, are inherited cancers. So there is a risk, or you have inherited a risk of having this tumor. And well, this changed all our cancer clinic consultation, or was found in our cancer clinic consultation. because before BRCA1 and BRCA2, we were not dealing, the medical geneticists, we were not dealing with cancer or inherited breast cancer because we didn't know. But since this discovery, once that you have in your clinic a patient with a breast cancer, you don't know if her cancer is inherited or not. So it's why we consider that this is important. Also, because we are carriers of a lot of recessive condition, and up to 20% of the newborns that are in UCUs are carriers of one genetic condition. 3% of all the couples, they have this risk of having this risk of 25% of having a child affected by a disorder. 30% of the sudden deaths are related with genetic condition. And, you know, with factor 2, factor 5, those clotting conditions are present in around 6% of the population. And what I think that is more important also is the elective pharmacogenetic profile that is so important to try to reduce the adverse effect of the drugs and to find the correct drug in the correct dosage for the patient. So as we've been talking this morning here, we are searching for different conditions. We are analyzing different genes, and could be a healthy setting or as a secondary findings in a patient. So also when we are doing diagnostic genome for a condition, a neurologic condition, we think that it's worthy also to have this elective, for instance, pharmacogenomic profile to treat the patient. So we don't think that it's only for healthy conditions, also could be for patients. That is worthy to pass the whole genome sequencing through our platform and to get the results. How we design the platform, or better said, how we select the genes to analyze and the conditions to analyze. Well, we have two statements. The statement of the ACMG about the secondary findings, those genes that is worthy to analyze if you are doing a comprehensive genomic analysis, whole exome sequencing or whole genome sequencing. So we expand the genes that there were in the statement, these 78 genes now. We expanded to 650, just adding genes for the same conditions. So instead of a study only 4 genes for inherited breast cancer, we added more genes, so for familial hypercholesterolemia and so on. So is why we have 650 conditions. It's around 500 genes. And similar for the carrier screening, we follow the recommendation of the American College of Obstetrics and Gynecology about the common conditions that should be screened in a pregnant woman or before pregnancy. So also we expand this list with another genes that are responsible for the same conditions. So with all this information, we construct the platform, and we are analyzing the whole genome sequencing of our patient. Whole genome sequencing that can be done in our lab or can be done in another lab, and they are sending us the whole genome sequencing. So if you have whole genomes that want to be analyzed by our platform, it's possible to do it, and we are working with different hospitals and institutions doing that for them. But the thing is that we have I think that a good selection of genes and conditions. We have this proprietary tool that Dr. Cirigliano has explained. We have a team of curators with very experienced, very experimented in curation, and mainly in these genes, because we are working all the time with the same genes. And also we have Vapor, that is our database, that also is every day enriched with new mutations in these genes. And in our service, always, it's not a direct-to-consumer service. We have always a genetic counselor or a doctor involved. So we need a prescription from a doctor, or if the institution or the hospital that is working with us, they don't have a genetic team to do that. It's our team in Veritas, our clinical team, who is going to do the pre-test and the post-test counseling. So our idea is using the elective genome is to move from the sick care to the healthcare. So to find the genetic predisposition, not only, as I will explain now, with monogenic disorders and with the pharmacogenomic profile, not only with that, also we have updated our database to do risk assessment for polygenic risk conditions. We think that this is the future of prevention, and not only in an individual basis, also in a social basis. We think that for governments and for health system, it's very important to stratify the risk of the patients and to focus all the effort to prevent the disease in the population that is really at risk of having these disorders. So the report is a big report and contains a lot of information. This information is in our platform, as Dr. Cirigliano was saying. Once that one of these variants appear in the analysis, there is already a write-up with the description of the disease, the actions of the disease, can be labeled, as we were talking before, as very important, or noteworthy. And here is the summary of one of the variants with the information that is important. This information is written in a very simple way. It's for the medical professionals, but not necessary for medical geneticists. So, because we think that, like in radiology or in other fields of medicine, the very specialist people should support that the people that is with the patient. So, if you are dealing with, for instance, with healthy people, this can be done by a general practitioner or another specialty doctor. During these 4 years, we have the experience to work with a lot of doctors, not only medical geneticists. If they need support, we can give them the support, or even in their hospitals, they can give the support. We have hospitals that are doing regularly these tests in their checkup units, and once if they have or they need more specialized advice or more specialized genetic counseling, they have the genetic counseling team to do it. So as you can see here in this slide, when we have one of these variants in one gene, all this information is going to go directly to the report, and the information is not only about the variant, it's also about the disease, the epidemiology, the mode of inheritance, so the actions that you can do for prevent the disease. As I was telling you, for us, genetic counseling is the important part of this. It's not only to have the result of one test and the variants of the information of the disease. You have to make a plan for this person to try to prevent the disease. So it's very important, this post-test genetic counseling, because it's the power of prevention of the disease is in that part. So as I was telling you, we make this first pre-test genetic counseling session. We sequence the whole genome, or we receive one file with the genome already sequenced in another lab. We do this analysis and interpretation for these different conditions and the genetic counseling post-session. So we have now the experience during these 4 years, and we have the experience, and Dr. Sandberg will talk you more about this, about the experience from day to day in the clinic. But we are preparing for publication some results of clinics, hospitals that we've been working with them, that we have the authorization of the patient and we have the approval of the ethical committee, and that we have the whole history, clinical history of the patient, so we can see all the aspects. And for the first, well, not for the first, for one hospital in Spain, Clínica Universitaria de Navarra, we have 500 patients very well controlled with all the records and everything. And we have found that clinical relevant findings is in 20% of the patients. Those patients has not been selected, were patients that they go to a checkup unit. So they are doing a checkup with different imaging conditions. They have, of course, an interview with a medical doctors, and 20% of them were carrying one of these red flag conditions. So it's like, and we will see in the Dr. Sandberg talk, it's related with inherited cancer disease, related with inherited cardiovascular disease, and so on. You have here the percentage of them. It's around 28% of cancer. It's very important, and we are confirming what has been described in another big studies like the Nevada Genome Project, that around 75% of the people that we find that are carrying one of these pathogenic variants that can put this person on risk, they are not fulfilling the conditions that we use to prescribe the test. So up to two-thirds of the population that are carrying one of these pathogenic variants are not screened at this moment because we are not prescribing the test. And this is very important in cancer, but also in cardiovascular disease. What we have updated, we have put in our platform as well the polygenic risk score. We have selected some polygenic risk scores, and in the report, we have this first report with the monogenic conditions, and the pharmacogenomic profile, but also we are screening for polygenic risk score for cardiovascular disease, for type 2 diabetes, breast cancer, and prostate cancer. We think that at this moment, those are very solid polygenic risk score. I mean that you can use it in clinical. So we are given the results in the whole genome sequencing. Once that the FASTQ goes to the platform, we get the monogenic information, my genome, and my health score, that is the polygenic risk score. As I was telling you, I mean, we have selected only this polygenic risk score because we think that they are very useful. We find it very useful in the clinical setting when we combine the polygenic risk score with the classical factors in the different calculators. Actually, in our webpage, we have one of these calculators, like the Gale calculator for breast cancer, and also another one for cardiovascular disorders. So we combine the classical risk factors with the polygenic risk score, and it's improving the risk calculation as we will see in Dr. Sandberg's talk. So here is the report. It's shorter than the My Genome report because we are screening for common but in less conditions. So we have in the first page general information about what is polygenic risk score, and then in a summary, like in the My Genome, we have if the patient has the lifetime risk is high or average. We are not reporting, of course, low risk, just we say average, and with different graphics, and some of them in the web version. For instance, the graphic related with the age and combining with the other risk factor can be modified, so the patient can see if he is modifying some of the risk factors, even that the PRS is a high risk, can be reduce the risk in relation with the risk of the population. So thanks very much. We will have then the question session, but now I would like to give the talk of Dr. Sandberg. Dr. Sandberg, please.
Thank you very much. So I was first introduced to this area as I would travel to Chicago to the ASCO conferences with a friend, Professor Ros Eels, a very well-known cancer geneticist, a remarkable lady. And after the second time, she suddenly said at lunchtime, Michael, why don't we do whole genome screening in your practice? So I didn't know what that meant at all, so I said, very good idea. And so gradually one got a bit of a feel, and there was maybe one good reason for doing it in our practice, which we had cardiology in the practice. We had the head of cardiology at the Brompton Hospital and his wife and an expert in stress echo. So we had some different resources because she was a cancer doctor and this needed to cover everything. So that was a good reason for choosing us. My genetic level of knowledge is well above the bonnet, even if that's being flattered. So what I'm trying to share here is I think this is eminently possible to put across into the NHS. It's not difficult. If you have a superb team like Veritas, do the type of quality work they have done, then you have a team of geneticists who have the knowledge across the fields to help you, and then a genetic counsellor. That GP can be very well empowered to make a big difference to a large number of patients. You don't need to bring in some huge dinosaur machine into the practice. It's all done basically with results and everything coming through online. So that's really how we started. And we started initially doing whole genome screening, and that was for patients who had to have a medical, ECG, echo, blood tests. They would have an MDT meeting to discuss their results, and then they would be seen by a consultant geneticist at the end of it. So that was very detailed. And then after a bit of time, one realized that's all very well, and it taught us a lot. But why not see how we start to cut it down to make it more practical so this can be realistic? So we took the first cut down step to doing what we call the preventive panel, and that involves roughly 80 cancer, roughly 80 cardiac genes. It includes 4 other genes which we find useful, which includes things like hemochromatosis, hypercholesterolemia, SERPIN-A, and then we have a number of polygenic risk scores. And so we find obviously the key polygenic risk scores are for breast, ovary, bowel, and the last one's going to come to me straight away. But essentially, by doing that, we feel you can make the difference to the patients. You've got to do high-risk genes, and you've got to do polygenic risk scores. And probably the polygenic risk scores, by risk stratification, will make the biggest gain in the long term to saving lives. So any conflicts of clan interest? My name is Swedish, Sandberg. My mother was a Duncan, so I just need to declare that. Thank you. Now, for those who feel they still would prefer to be in bed, I've tried to do this as a bit of a patchwork quilt to give them a bit of comfort. So I suppose what one's thinking is, what is the battleground? What is one up against? What's you got to make the difference? And so this very simple slide that we produced, I think, does that. So it shows where those huge deaths are in lung cancer, bowel cancer, prostate cancer, breast cancer, pancreas, and as we go across the slide, they tend to get smaller. And so then you have to think, where can genes make a difference? How much difference can they make together with polygenic risk scores? We think probably on a back end of an envelope, you could probably reduce cancer mortality by about 1/7, realistically. And that's because of using polygenic risk scores to identify those patients with bowel cancer, prostate cancer, breast cancer, these big, huge areas of cancer mortality are such a help. And I can show you, as we go through the talk, a bit examples of how that works. Obviously, there's smaller gains from hemochromatosis and liver disease. There's gains of pancreas genes and BRCA genes. And obviously, there's the bowel cancer risk genes, APC particularly, and Lynch syndrome genes. But as we move through, that diagram was just meant to show why one can make such a big difference. So what do you get? And this is out of 170 whole genomes and 63 of the preventive being that smaller, about 80 cancer, 80 cardiac genes. What are you landing up with the genes that come through that you have to deal with and help the patients? I'm not going to go through all of that. I'm just going to go through very few of them. An example, the BRCA1 patient. I walked into my friend's shop and said, how's life? And he said, well, it's not great, actually. My sister's just been diagnosed with stage 4 ovarian cancer, and I think she's going to die in a few years' time. So I said, well, I expect she'll have her genes done, and she came back as having a BRCA1. And so we did his, and he came back with BRCA1. We had a bit of a further chat, and I said, was there anybody else in your family who had cancers? And he said, well, yes, oddly, going back to 1994, my sister, aged 37, had breast cancer and died of it. Well, this is an example where it was because, sadly, BRCA1 and BRCA2 came in, I think, in 95 and 1996. They weren't informed about that. They were not a medical family, and they didn't have close doctor contact. And that's very sad. So his sister is dying unnecessarily. She could have her ovaries taken out as a lunchtime operation, risk closest to zero. And that's why we're all here, because of genetics, to talk about this. The BARD1, the PALB2, we need to be honest about some of these. Some of them came with knowledge of a sister. The PALB2 had a sister who had that, but she never wanted to action it. They didn't get on, really. It took a bit of saying this is really worthwhile doing it, and her risk of ovarian cancer is probably about 5%. She's now had her ovaries out. And the BARD1 came through as a surprise. She had had a breast cancer in her mother, but she's now had her ovaries out. And as we go through, I'm going to come back into the MSH2 and the APC later. I'd like to briefly talk about clot risk genes. So these are very common. So from that point of view, the F2 and the F5 variant changes, we find that probably F5 maybe give you a 4 to 5-fold increased risk of DVT and pulmonary embolism. But there's a lot of people to talk about, but it actually works. So to one of them, we had 2 of these patients had pulmonary embolism last summer, and one of them had been given a Pixaban. And so while it didn't completely do the job, maybe it saved his life. He'd been doing some long flights. So we only would suggest they do it for flights or serious big surgery and flights that would be longer than 6 hours. We talk to them about if they're in hospital for a long period of time. So it's just the common sense advice, but you just need to know that, not waste time, and be well informed. Obviously, there's quite a lot of KCNE1 genes with the risk of prolonged QT, and then there's just a balance of information to those patients that this is not a big deal, but just avoid those drugs, which will increase your QT interval. Then there's more difficulty, the cardiac genes. So from that point of view, we have that lower penetrance from any of these genes. So with any screening situation, you're thinking about how much good do you do and how much harm through worry do you cause. And with those patients, that's incredibly sensitive. And as a doctor, you have to be very careful to have quite a lot of knowledge before you start talking to that patient. Giving him that information, he may have, say, for the PKU patient, the risk of arrhythmogenic right ventricular cardiomyopathy, probably his risk is between 30 and 50%, but that will penetrate in his lifetime. That's a difficult subject to talk with somebody. But if you don't do it, those people die sudden deaths. So that's the balance. So it's very sensitive. You have to think towards him, has he got life insurance in place? Because the moment you push the button for cardiac MRI, he's got that stamped on his notes. So that's the sensitivity. And I'm glad to say, through the huge support of the team of Lucy Side, who's head of Wessex Cancer Genetics, Tessa Humphrey, who's an expert in cardiac genes and also in children's genes, absolutely brilliant lady, together with Gabby Pishett, who was joint lead of head of cancer at Guy's for 10 years, and Roz. We're very well supported. And I think that's part of the key for doing genetics, is be supported. We also set up a concept of 5 commandments for genetics. That was actionability. So we don't do dementia genes, we don't do Parkinson genes. We're just doing genes that you can make a difference. Some things obviously come close to that or can have overlaps where they may have lots of benefits as a gene, but they might have a side effect of an increased risk of pancreatic cancer, say from MSH2, whereby that's not so actionable. Accuracy. Veritas are just great. And why are they so good? They're excellent communicators, and when we've had problems, and a couple of times we have had problems, their dedication to sorting out a system that it can never happen again is brilliant. So they're very friendly, they're not condescending to us, and it's a fun relationship. Consultants being heavily involved in the whole process somewhere is always going to be key. And then there's the MDT meetings, and then there's the actual end result to the patient and written data, so that's understandable for their own doctors. Thank you. So just very quickly, a couple of colon cancer cases as examples. So this particular patient slammed his hand down on the desk, said to me, Sandberg, why did I get colon cancer at about 35? You sort it out. So we started off, and he had his genetic screening, and he was found to have an APC mutation. But speaking to the geneticists, they said, no, 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 Sandberg, that's not terribly important. He's got basically a close to a 2-fold increased risk. That's not going to completely explain it because they knew about that particular founder mutation. But as we went on from there, we finally got his polygenic risk scores, and he was on the 98th centile. So then we did have the answer. And as you probably know, there was a presentation last year about the interactions of genes and polygenic risk scores in bowel cancer from a specialist from Bonn, which has not actually yet been formally published, which showed the staggering influence. So we'd explained it to him. A second patient, he'd had colon cancer, again very young. And he'd had another cancer, which I won't mention for not identifying him. So he wonders why that's happened, and this poor man's had chemotherapy twice. Anyway, he lands up, his genetic test shows he's got Lynch syndrome and MSH2. That's difficult. So he comes in, he's had 2 cancers, and now I'm giving him another blow of telling him he's got Lynch syndrome. It's a blow in one way, but you've got to work together to help him to understand. By that knowledge, his mortality is reduced 25%. It's improved 25%, I should say. And so then that also he can take aspirin to drop the risk of colon cancer by 40%. Separate to that, the big deals is he could have had immunotherapy. So this poor chap, due to having had chemotherapy and steroids, he landed up having a hip replacement due to osteonecrosis. He landed up having the other hip drilled, and he landed up having bone taken out of his wrist. Quite a lot of disastrous, a huge weight of load of this illness on this man. He could have had immunotherapy. He didn't need to have any of that. And then the next part of it is, yes, he'll have his screening for his colon cancer regularly. He'll have his obviously man, so he's not going to have that uterine cancer risk, but he's going to have his gastroscopies, his renal tract scans, etc. But the next part of it is thinking about his children. So there's a 50% chance of going through to his children. But that's quite a heavy load for him to feel as somebody who came in just having suffered himself. But then you explain to him, you can stop this going down through to your grandchildren if they have it. So there's a 50% chance they will have it, but by PGD, that curse of this can stop. So that's just 2 bowel cancer cases. I want to show you now briefly the polygenic risk scores. It's quite strange. So we send off all these samples, and they come back as a load of X's what their bottle numbers were. And then it's when you reveal who these people actually were that was one so impressed. So if you look at the top 20th centile for the colorectal distribution, you can see that there's actually 6 of these if you include somebody who had a 4-centimeter polyp up the top in the green. And there's just 2 outside. The other part of it was if I looked at my own patients, I'd had 3 who'd had cancer very young of colon. All 3 had polygenic risk scores above the 80th centile. So we're talking at the moment about this colon cancer nightmare that essentially the commonest cause of cancer death in men up to the age of 40 by 2030 is going to be colon cancer, not lung. So how are you going to beat this? This is a large part of that answer. We go to the prostate. Out of the 104 genomes, I'm a huge fan of medicals, and it was odd. I landed up diagnosing 6 new cases of prostate cancer. 5 out of 6 were Gleason 3+4 or above, so they were worth diagnosing. Very strange. So the newly cases that were diagnosed are in the triangles here in red, and other cases who had previously diagnosed in red here as circles. Isn't this amazing? Look at here. Pretty well everybody other than 2 in the top 20th centile have got prostate cancer. One of them's about 35, one of them 43. This is going to be a massive area of change. So as a GP, I have the privilege to know Ros. I knew Claire Allen very well, who's probably one of the world's experts in MRI. So it was much easier for me to screen patients because I wasn't going from a finger in the bottom and a blood test straight into a rectal biopsy and risk of infection. I was going from those tests, understanding rate of change of PSA, PSA value, free total ratio, those are the indicators, plus my finger, maybe adds another 10%. And you're then going into an MRI, where is it, what does it look like, Claire's massive expertise, and then only finally into a template biopsy, which is obviously transperineal biopsy, which is such a lower risk. So it was easy for me. So I've screened all my patients during that time, and I've had 1 who's broken through to get metastatic prostate cancer, only 1. So it works, prostate cancer screening. It doesn't need to be this big killer. So long as you share with men that some people think you have to operate on 6 people to save a life, whereas breast cancer is 3, and you will make 50% impotence. But I actually think it will be better than 6 to 1. I think it will be very close to 3 to 1. You can pick which Gleason scores you do. You can choose the people who've got localized lesions not near the capsule, who don't have high Gleason scores, and do focal treatment. And Ros might say, well, all that prostate has the genetic time bomb. They've all got the same genes in every cell. So, Michael, it's going to go wrong in time. But if you can preserve somebody's potency for another 5 years, that's great. So I just want to give you a couple of examples here. This man came into our study, and he basically was found to be on the 98th centile for his prostate PRS. So his urologist said, I don't really care very much about that. You know, please, his MRI and PSA are okay as far as I'm concerned. Please leave him alone. And Ros said, well, I know I've got my Barcode 1 study, which is going to come out in 2024, June, and I know what that's showing, and he's got a 6-fold risk. Would you mind if I biopsied him? He was biopsied, and he had a prostate cancer greater than 3+4. So his life was maybe saved by having that genetic PRS. We look at the man here on the right side, and he came to me late as a new patient just a few weeks ago, and he had metastatic prostate cancer. But if he'd had his polygenic risk score, which when we did it, he's on the 96th centile, again, he'd never needed to suffer metastatic prostate cancer. He was at very high risk. He would have had a biopsy earlier on in his life. He would have proper screening. So this is a massive area where you can make a huge difference. So if we think of bringing back a 7th of our patients, our friends who died of cancer, you could bring them back into the room to join us, and all the grief for their families, the hell of their treatment. That is why we are here today, the massive difference. But the problem we have is communicating it to patients so they can understand. It's like going into a fortune teller's tent, isn't it? Many people think. But we're not like that. We're only telling them things where we can help. But it's not easy. So my probably key role was persuading these patients to do this test and helping them to see the benefits. And that's from a GP who knows these people well, and probably they know I'm a bumbly fool, I'm bad at paperwork, but they'll trust me a bit. And so that's a much easier relationship to have something work out, to help somebody say this really works out. But it is a huge obstacle. So I call it the ostrogene, the person who doesn't want to know. Whereas I've got another picture of a person with a T-shirt on it, and it says, the test didn't give it to me, I always had it, and across it says, now I can do something about it. And that's the sort of simple message I try and give to patients. So lastly, just these slides showing the extraordinary influence of polygenic risk scores upon genes themselves. So this is just an example that Ros kindly gave me from Nyberg's paper of this year. And this looks at patients, they all had BRCA2 pathogenic variant. And what she looks at is their polygenic risk score, how it interacts. So you can see this polygenic risk score on the 5th centile has something like a 20%, slightly above it, lifetime risk, whereas up here, if that patient there is on the 95th centile, they're right into the 80th. It's a massive effect. So if you're going to do genetic screening, goodness sake, do polygenic risk scores. And that's the effect of a family history. And the effects are down here for BRCA1, showing again with that polygenic risk score of, say, 5%, with all these patients having BRCA1, that risk is very low indeed. But if you take it across up to here, onto the 95th centile, that's a huge difference. You're right into the sort of 37th, 40th centile, and if you have the family history. So thank you very much indeed.
Microphone? Is it on now? Yeah, okay, great. So now our plan is to have everybody come up and sit in front, the 4 speakers, and give everybody the opportunity to ask some questions about the content. I just want to say, you know, I've been in the genetics world for about 5 years now. Before that, I was in insurance, you know, health insurance, a little bit of everything, and I had the opportunity to join, and you can imagine it started with the marketing brochure. I'm like, wow, this sounds amazing, but I didn't really know anything more than that. Didn't know what a variant was. Didn't know what and now, thanks to these individuals, 5 years later, I actually paid attention and understood 80% of that presentation. So I'm very excited about all of it, and obviously just the people we have here and the story and the progression we've made is very is very amazing. So obviously, thank you for the participation today. I don't know if anyone has any kind of any questions or like to ask the speakers. If not, I have a few that have come in online, but go ahead. Yes.
Yeah, you mean expansion, right? Yeah. Triple expansion. No, we cannot do this at the moment. There is some bioinformatics going on to improve this, but at present, no. If this is for the carrier screening section of the report, yeah, sure. Yeah. For the carrier screening, actually, yeah, is like only a section of what we can do, the comprehensive kind of analysis that we can provide with the limitation of the triplet expansions. So if it's, the indication for the study is specific driven by request of carrier screening, comprehensive carrier screening, should be done either with another test or complementing for a common condition that had to be screened separately with different technique like PCR fragment analysis. So.
And the deep intronic mutations, like in the CFTR?
Yeah, if there are deep intronic variants, if they have an entry in ClinVar, they will definitely show up and be filtered. If not, we are not going to report those anyway because most of those will be VUSs.
Thank you.
I don't know if anyone else has a mic here, but I don't know if anyone else has a question. If not, I'll start with some of mine that have come in. They have a few people joined online, and I just want to. I know that starting. A question everyone asks is for health individuals. So how do you get this? Make health individuals aware of this? And there's a lot of direct-to-consumer activity. There's a lot of marketing around that. You look at some of the basis of genetics. Direct-to-consumer has been more ancestry, but we feel obviously that this is more impacting on a person's health care. I would like to ask Michael for this, Dr. Sandberg, what do you see as far as the risk of a direct-to-consumer, a person choosing this through the physician process and consenting and consultation? What do you see as some of the risk?
I think they get enormous shocks, and I think it's pretty disturbing. So we have the occasional doctor who's gone and done a test themselves, and I think we had one who landed up, I think, having BRCA, and it's a pretty big deal, and she's done a prophylactic mastectomy and everything like that since. So, but she's a doctor. If you then go to a different level, I think it's chaos. I think it's a disaster for the reputation of genetics. We sort of shared how difficult this is to do well and in a way that's acceptable. If you do this in that type of way without counselling, it's going to give it a terrible reputation with a huge amount of problems. And how many people do I have nobody said to me, I regret doing this. I've had one person who was quite cross with me who has a pre-leukemic gene, and he just said, Sandberg, I told you, I just wanted to find things that I can do something about. But he'd gone through a recent bereavement. It was mixed in with other pains that he was going on with. His dad had just died, and it turned out his brother had actually had leukemia. So it all linked together, and he cooled off. But if you don't have the knowledge, I think you're going to have quite a lot of chaos. I don't know what you all feel.
Yeah, sure. I think that this is one of the most dangerous consideration for the bad reputation of some genetic tests. To do it, when some of the direct-to-consumer company introduce not only fun genetics, that is okay, but genetics for medical conditions, and they used to give a false feeling of to be safe of having this condition. No? So it's why, well, I think that in most of the countries, at least in European countries, it's well regulated that you cannot offer genetic testing for medical conditions without the physician involved.
I mean, for a cardiac condition, that's particularly the type of thing where it's extraordinarily awkward. They're suddenly involved in having a frightening potential possibility. If they go and get the tests, they've got that on their life insurance. They've never ever thought about it. They've also got the aspect that it affects on the rest of their family. They've also got the fact that some of these conditions aren't paid for, say, in the NHS. So if you get that, the only way you're going to follow it up is by paying it for yourself. It's a lot of difficulties, isn't it?
All right, thank you. Another question has come in is I know that we say a lot in the presentation. It's on one of the aspects of having your whole genome sequenced is the information's there. You have it, and as the technology evolves, you can reanalyze the data and find out more about yourself. I just want to ask Vincenzo, as far as what is the process as far as how do you go back and reanalyze the data, and where's the data stored, or how do we do that as far as how do we keep it, how long for our patients, as far as, so how can we make that possible?
Yeah, well, actually one nice example was just the question that I was getting earlier. Because I said we are not currently reporting on repeat expansion, but this is something that is we are heavily working on, and soon will be possible. So we have the data stored in our environment, and we can rerun even different pipelines to get out different results and information on that. So. Same as we are doing with the PRSs, with the polygenic score. They were not available when we started back in 2014. So, yeah.
Okay. Good.
Does the patient has to ask for you to do it, or you do it?
Yes. Well, of course. If it's for updating a condition where we were already consented to test for, that's fine. We can do this straight away and communicate to the patient. But if it's for a different sort of intended use, we need to recontact the patient and have the another request and an informed consent. But as most of our patients come from hospital or clinic, is not us, contacting directly the patient, but most of the time is requisition coming from the centers.
Okay, thank you. One of the other questions that I wanted to ask, this is for Joel. We talked about a lot, he covered in his presentation as far as how the technology's evolved, and I know we've focused a lot on elective genome screening in a clinical setting, but I know that the advances that were especially made with the new machine, NovaSeq X, what do you see as far as outside of this small part? What do you see as some of the larger evolutions of the technology and where it can be utilized?
Yeah, thanks for the question. It's been really exciting to see this evolution or maybe revolution in genome technology and what's possible. When I think back, not that long ago when we enabled the $1,000 genome, there was roughly a few dozen labs around the world that ran genomes themselves, and the number of genomes that had been sequenced could be measured in the thousands. We're now in a world where we've had over 4 million genomes sequenced. There's hundreds, maybe thousands of folks around the world sequencing genomes themselves. We have amazing folks like Dr. Sandberg who've put this into clinical practice, and I think just seeing this explosion in whole genome sequencing is really, really exciting and rewarding to see. And I think a big part of that has been just this evolution of our sequencing technology, making genome sequencing much more accessible, driving down the cost, increasing the throughput and capability, and the entire time improving accuracy of the technology along the way, and also working on the informatics side and how you can very quickly and seamlessly analyze and process the data. It's absolutely been a revolution over the last 5 to 10 years and incredibly rewarding to see.
Well, great, thank you. All right, well, I don't have any more questions. I don't know if anyone else has anything else. If not, I want to thank everyone for joining us today. Thank especially the speakers for doing this. A lot of work went into those presentations, and yeah, it was very, very interesting for me, and I'm sure everyone else. So thank you, everyone, and yeah, everyone here. Enjoy the rest of the conference. Huh?
Thank you.